Please help spread the message of Frequency Specific Microcurrent by clicking on the like button. You can subscribe to us on YouTube or any podcast app. If you have any questions, please leave them in the comments. You can find the podcast transcription at frequencyspecific.com, as well as more information about Frequency Specific Microcurrent.
You tell us when we're on, Kevin.
It is 3:50.
Hi, everybody.
Hi.
We did it every year. We're back. We're okay, good.
And
we can edit the beginning, but
beautiful downtown Chandler, Arizona.
we're in Arizona. We're together. We're not on a screen.
I watched them.
We are here, and we actually can't really see, but my blue pants actually match with your blue suit.
My jacket.
And we
Cool.
tend to do this a lot and coordinate our outfits. And
We do. And they're pretty close to identical,
They're-
which is hard
they're-
to do with this color blue.
the blue pants are just saying, bring me to Phoenix.
Okay.
I don't argue with the blue pants. Darn it, I didn't take a class picture. It's okay.
We got a class picture of the core, and I was going through my pictures on my phone for no good reason,
Well,
and found the pictures from the advanced in 2020, the one we did the month before,
oh, right.
COVID
Do you-
started.
I remember that.
Yeah, like it was huge. We had
Yeah.
150 people here.
And I remember we were just starting to talk about it, and there were so many different people's opinions of what was going to happen. Everything from we're going to be fine to everybody run for cover right now.
And there was one person who wanted us to cancel
Yeah.
the advance because there was going to be a virus. And so I ignored him. And then I got on a plane and went to Manchester, England to do a lecture like the week after the advanced. And then I found pictures of Kennedy Airport with no people, me and nobody else in all of JFK
Wow.
in New York, coming back from, I was on the last plane allowed into the US. We've done a lot in the last 5 years.
And we were talking about the origin of the podcast, and it's not like you or I ever thought, let's start a podcast. It was you or I going a little bit crazy during COVID because we weren't traveling and we didn't have practices and we didn't have all the things that normally pull us in a million directions. So we decided to Zoom call and geek out and tell stories. And I was asking questions, and it was this whole Yoda and Luke dynamic.
I get to be Yoda.
And we'll give Kevin some credit for him mumbling, this would be like a funny podcast. And then it was like,
No, Kevin's exact words were, you guys should do a podcast. There was no ifs, ands, or buts. It was like,
so,
Kevin says so.
and it came together so easily. What day? Wednesdays. Yeah, Wednesdays are great. And we started
There we go.
doing it. And
And so here we are. We didn't do last week because I was in the middle of the core.
Yeah.
And she got to be at home, and yay.
And now we're here, and I just finished the sports course an hour early. So we made people get up a little bit early today so that we can end a little bit early so they can come here
So
and
we
we
can
can do
still
this.
do.
We can still do this.
Yeah.
Yeah.
Did you have anything magic happen in the sports?
There's always magic. So we do a lateral recumbent or side lying shoulder practicum that I like to, we are very the same and yet we are very different. So I think we are congruent in a lot of ways, and where you have to teach the rule and the law and the alphabet, I'm like, here we get to scramble up all the letters. So I was showing some side lying and some different ways to do shoulder. And we did some very, what I would say, maybe magical range of motion. But I'm like, this is not going to hold because I haven't taught them the part that makes it hold yet. So I find that's a very frustrating part.
Yeah.
And I give you so much credit for teaching the way that you do, because the sequence is important and that's what gets the results. And you can't teach A before B and C.
And you have the advantage of having people in your class that want to do sports, so they know how to use your hands. In the course seminar, we have non-practitioners who are not allowed to touch people. I think you might have to move that way. Are you okay? Yeah, we need to have you move.
Oh, you're in the podcast.
Yeah.
It's okay. There we go.
There we go.
Yeah, we're live. It's okay.
Right next to Sandra. Anyway, in the core, we have everything from non-practitioners who are not allowed to touch anybody to medical physicians, osteopathic physicians, and physical therapists who know how to work on shoulders, although this was a gastroenterologist, so shoulders are a little above his pay grade. And then we have PTs, OTs, acupuncturists who have never worked in their life on a shoulder. And so I have one way to treat shoulders, supine. So we keep them out of trouble, let them do something that works. If you put your finger in their armpit and do that with your fingertips, watch their upper lip, and you'll know you're in the right place when they go.
I still use that.
Yeah. And if the person was on their side, it's hard enough teaching them to do it supine with the patient supported on the table. So I'd love to be able to teach side lying, but that's actually not going to happen. Don't get your hopes up.
Yeah, that's why you have me. If you want to learn that part. And so I think that's maybe that is the whole magic that gets to happen, is I get to take a base of knowledge and then branch it off and say, now you can try this with it. And if you're really tiny and you have a large person, move your body this way. So I wanted to, we talk about the word safe all the time. The curriculum is safe. The device is safe. What we do is safe. The patient has to feel safe. But the focus that I try to also put forth is to keep our practitioners safe, keep their body safe. Like I said, I celebrated 25 years in practice a little while ago, and my hands and my wrists and my fingers and everything works because I had good mechanics. And FSM came into my life and did all the heavy lifting for me. So it just, that point is, it's great for your patients, great for your clients, but great for you as practitioners that you're able to take care of your bodies. And so safe.
Speaking of safe, we had the conversation that we have had on and off about hypnosis and how every patient that you touch is automatically in a state of hypnosis, physically relaxed, mentally focused, and a point of contact. It's pretty much all it takes. It's easy. It's actually hard to keep them from being hypnotized. And for the first time, I think ever, I know for sure it's the first time we've ever gotten it on videotape, but it's the first time I remember it happening 2 or 3 times in one course.
Wow.
We were working on the patient's shoulder, and for whatever reason, the patient had the memory of a trauma, wasn't related to her shoulder, but when we started working on her shoulder, got it to move, we got the job done, but all of a sudden she's sobbing out of control. And the practitioners are saying, we're going to do 94 and 200, 40 and 562. It's no, we're not. Look at this person. I didn't say it quite like that, but look at this person. This is the hippocampus driving the bus. And we caught the whole thing on tape because David was in the right place at the right time, as he usually is. And we just switched it to 40 and 89. And I put my hand interact, which was the trigger.
Right.
And I said, it's like wherever you're back when it happened and your hippocampus is driving the bus, and I want you to join me here. And I just, come on. Waited until she made eye contact and kept physical contact with whatever it was that triggered this. And we ran 40 and 89, I think, for 15 minutes. And the words that came out of my mouth were, "You're here with us, stay with me, you're safe. Stay with me, you're safe." So safe was the word that came to mind. And we ended up, there's more things that happened. It's now in the Practitioner, or it will be when David gets home and gets to edit it. It's in the Practitioner resources or practicum sessions. And we titled it Hippocampus Hijack.
Yeah.
And it happened twice. And the key is that when the hippocampus gets overwhelmed, hippocampus has as its job to remember every bad thing that ever happened to you.
Yeah.
Now, why these people stored this memory in the second person, it was down below her scapula and right where the lat and the serratus cross. And she said, that's old. Okay, this is not the setting to ask somebody what happened, because if it's that old, it was probably something not very pleasant. And it's, once again, kept my hand there, ran 40 and 89, took about 20 minutes, but the words were exactly the same. You're here now, and you're safe. And if you can engage their cortex, it's kind of like we want to teach all of the core all at one time.
Yeah.
So we've started this, thanks to you, very early in the myofascial section, where we talk about connecting, quieting down, afraid to move it, which is the midbrain, quieting down the cerebellum, which is afraid to move it, quieting down the sensory motor cortex that thinks it still hurts,
Right.
and then increasing secretions in this. So we start that very early. So when we're doing the shoulder, the concept that the shoulder is connected to the brain was not entirely novel.
Right.
But the trick was to get the cortex engaged, because the cortex can override the hippocampus,
Right.
if we are cheating by actively turning the hippocampus down. But that happened 3 times in 5 days.
It's a lot.
It was exciting.
It's great though, I think, like any in-person course, I get it. Online learning is very convenient. It's nice to watch slides at our pajamas from our kitchen table. However, when you go to the live classes, there are little
Nuggets.
situations, nuggets that occur that are such a great learning. That's why we have so many practicums. That's why I encourage everybody to try to change groups and move around the room and touch different tissue and hear different stories, because that's where the learning comes from. And so that when you go back to your practice, you're like, wow, there was somebody at the course that had a shoulder like this or had a story like this, because your patients are going to tell you information, and it is information that you hear with FSM ears is completely different than your previous FSM ears. Do you know what I mean? I would only care about mechanical injuries. I wouldn't think about the frozen shoulder that occurred right after her kids moved to college and a hormonal imbalance happened and an autoimmune disease occurred, because all I would care about is smashing apart the subscap, not treating the vagus first.
Yeah, there's that.
You know what I mean? So we try to pick up the pieces, but it's funny that we're talking about safety, because the topic too about how our words, our patients come to us because they are in pain and they want help, and we have to create that safe environment. And our words mean a lot, especially with FSM in the room. So saying things like, ew, that's gross, or that feels crunchy when they're prone is not the negative stuff that they need to hear. So again, going back a couple years to the last time Roger Billica was here, he was talking about the placebo effect, right? And the nocebo effect. And I don't know, there's so many people that are like, I don't know, this is probably just placebo. I think it's just the warm towels. I just think it's the room. I just think it's you. Okay, let's unpack that for a minute. You came to see me with a 6 out of 10 pain. And after 1 hour, your shoulder has 25 degrees more range of motion and your pain is now 0. Does it matter? Really, does it matter if it's placebo or not? If somebody comes in with restricted range and pain and they leave and there's no pain. So we have this great placebo effect that we can probably all agree exists. But the nocebo effect, as Dr. Billica was talking about, is very real. And so his analogy was when people see him, you can't say words like fight. I'm not fighting my cancer. I'm curing my cancer. I don't have a torn shoulder. I'm healing my shoulder. So going back to 124. Oh, and I have to switch. Now I'm the one that's diverting the train.
Okay.
As I'm speaking, I see somebody sitting at the back of the room on the floor. Dr. Cross is sitting in the back of the room listening to my lecture.
Dr. Cross.
Diana Cross had snuck in the room without me seeing her.
Oh, Diana's here?
Yes.
Oh, for heaven's sakes.
And it was serendipitous because we were just about to break for lunch and my next topic was all about 124.
Oh my God. So you have to understand that Diana Cross has been digging into constantly for the last, when did we fix my 2010, Kathleen? 2010, 9. It was after my hip replacement. So it was 2010. I had an Achilles tendon tear that I'd had for 10 months. Started pain in January and I treated it with FSM and we had PT and for 10 months. Nothing happened except it got worse. So it was the size of 2 thumbs. And Kathleen Casman and I were sitting at an expo booth and I had run inflammation. I'd run everything I could think of. Kathleen said, this feels icky. And she picked 124 and the round tendon, which is the Achilles. And in 60 minutes, the Achilles was normal size of my little finger. Now you can say, size of my little finger. And I wrote to my brain trust, Roger Billica, Ben Catholi, Diana Cross, the gang, and said, okay, what did we just do? So the next year, Diana came and did a lecture at the symposium on torn and broken and how it worked. And then she came back and did it again. And unbeknownst to me, she's been working on it for the last 2 or 4 years. And so her lecture at the symposium this year is on how 124 is actually working.
So I was so excited to see
Yeah.
her sitting there and also a little scared, right? Because I'm about to say something and I'm like, I hope it is congruent with Lord Cross, right? We bow down to, right? We had lunch and I wanted to front load it. I'm like, I'm so excited that you're here. It's actually crazy that you're here of all times, right before I'm going to talk about recovery. And so the sports course is bundled into categories of rehab, recovery, and performance. And the recovery section is all about vacating debris from an area, right? And when we have athletes, or even when we have anybody that's doing exercise to get something stronger than it was, we expect some tearing and some repairing. That's what hypertrophy is. That's what we want. And with that comes a whole host of things. And everybody knows how I feel about using ice. And now we're using heat and all these other things. But with athletes, that's been the claim to fame with FSM, is they didn't need all the ice. They didn't need the ice baths. They were able to recover so much faster at home. And of course, I'm thinking, what on earth are we doing? What is allowing them to recover faster? What is the mechanism of the action? This was keeping me up at night. And so Diana Cross and I got to geek out a little bit, and you should have, I don't want to be like the spoiler alert about how 124 works.
She figured it out.
Yeah.
Yep. Well, she figured it out last time,
But she really figured it out.
but this time she really figured it out.
And then she's like, don't you think that makes so much sense? And I'm like, jaws on the ground. I'm just like, that makes total sense. And it's one of those things like, once you see it, you can't unsee it.
Yeah, no, it's like, I remember from last time, she had it figured out, but she didn't have enough time. When you give Diana Cross 60 minutes, she shows up with 97 slides.
Yeah.
It makes it a little tricky.
Yeah.
But she figured it out.
Yeah.
Increase ATP by 500%.
Yeah.
And then set the cells to work.
Okay, it's so funny that you say that, because we were talking about, sorry, it's total geek out moment here.
She's happy.
I'm so happy, you have no idea. I like sprinted to Chop Shop, grabbed my salad, choked it down. I'm like, hey, tell me more. I've always believed, and this is before we met, and this is before everything, I've always believed our abilities want to do good. Our bodies are like really obedient golden retrievers. Just tell me what to do and I'll do it for you. So that's why I enjoyed the osteopathic manual therapy route, because it created space for the body to go into alignment and do what it was supposed to do. I could get my head around that, not with high thrust manipulations and not with forcing things into certain areas and bracing. And it never felt organic to me. So this creating space and giving cells the ability to do their job just makes such organic, deep sense to me.
Get things out of the way,
Yeah.
remove the pathologies
Yeah.
from the tissues,
Yeah.
support secretions and vitality.
This is not that hard.
It's not that hard.
And once you see it, you can't unsee it.
Totally.
But then you become a perfectionist, right? So then you create the magic, you get the range of motion, you decrease the pain, you get them sleeping, and then you want to do more and more. And this is like where I feel like I'm
On the small print someplace, you can only do more if the patient wants to do more.
Yeah.
They told you that.
I just enjoy what I do.
But it's so
so
much
much.
fun.
Yeah.
Because you work with athletes that actually do want to move. Do more.
You know what? And the practice has completely changed. I shouldn't say completely changed. I see a lot of people who are in their 80s who are very sick. I see people who are going to the Olympics. I think everybody wants to move. I think everybody is an athlete. And my job is to get that movement pattern as safe as possible. So whether that is squatting 400 pounds or doing a lift at the Arnold's and winning first place. And I have a picture to show you that is so cool.
Seriously?
After an avulsion.
Oh, no way.
Oh, way. Or getting my octogenarian to sit on the toilet and then get back up again. It's a squat. And so for me,
True.
I do not care what the platform is. I want somebody to move freely and safely and effectively. That is it for every single person that walks in.
And you did ask for more complicated patients.
It did. And I will ask now for the universe to hit the brakes on that, because I feel like my vessel is filled, but with the complications has also come such a vast network of support. And I think because we have so many options on how to fix people, that can become very overwhelming at the same time. So I don't feel like any of us should be a master of all trades, jack of all trades, master of none. I don't feel like that fits in healthcare, but I have all the jacks that I can call. So I can call or text Ben Catholi and Dave Burke and you and Charlie and Jen. And I have so many people I can say, this is my thought experiment. What do you think? And everybody's so kind. They're like, that's a good idea. But
And they don't even say but.
No.
They say
and you could also try this. And you're just like, oh, I didn't even think about that.
Yeah.
And I don't feel bad that I haven't thought about that, because how would I ever know that?
You know what I really like that you just said?
What?
That a squat is a squat.
A squat
That
is
the
a squat,
same
yeah.
principles that we apply
Yeah.
to an athlete applies to somebody that's been in chronic pain
Yep.
for 15 years
Yep.
with mold,
Yep.
with deconditioning.
Yep.
And we're basically doing the same stuff, only we have the same tool.
Same tool.
A
Yeah.
squat's a squat.
Squat is a
I
squat.
like that.
Thank you.
Yay.
You can take that anytime.
Yes.
We're here for sharing.
Yeah. If I put any more slides in the core, they are actually,
So the core is now 5 days?
yeah, it's been 5 days for quite a while.
Yes.
And just so people know, I went from 146 slides to 125 slides to 122. I ran across 3 slides that I said, what are those doing here? What would happen if I just took them out? Kim covers them anyway. Everybody should take the rehab class after they take the core. They're going to get those 3 slides there. So I don't have to do those.
I do have to tell a quick story about when I wrote the sports course, and I thought it was going to be so easy because I'm like, this is what is in the core and this is what I have to do for the sports or the rehab. So I put it all together and then I'm like, it doesn't work because they have to know this before they know that. How are they going to learn that if they don't know this? Carol, what do I do? So I get it. The core is long and it can be overwhelming, but the strategy behind the sequencing of the knowledge is quite brilliant,
It's
I have to say.
come along very nicely. And the way you know that is we start at 9 o'clock on Wednesday morning. This week, they were tearing down the room, moving things out. People were still treating each other
Yeah.
at 7:45 Sunday night.
Yeah, because they can't get enough.
Yeah,
Yeah.
it's because, yeah,
Yeah. And I think that's what you want. You don't want people to race out of there. And it's hard though sometimes. I've been in the room where I'm like, I want to stay, but I feel like you have to jump up and then just hack your brain. So, okay, is there some more room for knowledge? No, just get some more in there because it is a lot. And you start thinking about everybody that you have to call when you're back in your practice because now you have an idea of how to fix it.
yeah. I think that's why the food is so good here in Arizona,
Oh,
because they have this delicious lunch, they visit with each other. And then during the breaks, they go out and lay in the sun and
Yeah.
you can see words and
yeah.
concepts just laying all over the ground as they fall out of their ears. And then after lunch, we start all over again.
And it's, yeah, these little mini conversations and thought experiments that are happening. Even the questions that I get, have you thought of doing this before? I'm like, no, but that's a good idea.
Mhm.
And I'm not opposed to it. And why don't you try it? And I'll try it. And then we'll compare and see how that works.
And then I heard from somebody this week, and I wish I could remember who it was, but he said he was treating osteoarthritis of the knee, and he had a fair number of visits with the patient. He just kept treating the knee. And then, I guess because he ran out of things to do, he treated leaky gut one day. And the knee pain went down by 80%. Excuse me? Okay. And then, same guy, different knee, it's leaky gut, liver detox. The knee pain went down by 80%. Okay. Where do I put that in the core?
I don't know because I am also thinking
What?
how.
You reduce inflammation.
Yeah.
Reducing inflammation. If you treated leaky gut, what would be the effect on the vagus? Oh, we're fine down here. So the vagus tells the brain, okay, we can turn down inflammation. And maybe that's all I can think. I made that up. It's not like I know what I'm doing.
No, but
I just make stuff up.
no, but this, okay, but let's go with this for a second.
Okay.
Come with me because
right.
I've been traveling down this frozen shoulder pathway for
Mhm.
years and doing that talk a couple years ago. And I was putting out type 1 and type 2, and I knew there were 2 types, but I didn't really think about the 2 types. Type 1 is our disease pathology triggered by hormone, immune, psychological stress, systemic autoimmune imbalances. Our secondary is trauma, slips, falls, anything that's caused that shoulder to get stuck.
Oh, okay.
Those are easy.
All right. I thought we were talking about diabetes. So now we're talking about type 1 and type 2 shoulders?
Yes,
Oh, okay, sorry.
yes, frozen
I
shoulders.
got left behind with
No,
the
no.
diabetes.
No, but
Okay.
diabetes comes in type 1. Okay, that's the kind
Got
of
it.
the disease onset frozen shoulder.
Got it.
So when we're doing our history, how long has your shoulder been hurting? Has there been trauma? There's not a lot, but then we hear of all these other systemic or psychosocial factors that are there. So when we go after the vagus first, that is why the inflammation everywhere else. So that makes sense. So it's the same thing. We're going after the vagus and it's treating
Yeah.
the gut.
And I've had to keep my mouth shut for 4 years because the data wasn't public. I did the Vegas webinar. Do you have any proof? Not yet. And now that the data has been patented for the company that's developing the external vagal nerve stimulator, Saturday, you'll get to see the data about what the vagus does and why it is. We have a patent on the specific sequence of frequencies that we call vagal tone. Yeah, for that company. But the frequency sequence is patented because we have data.
We have data.
So when
Are there any questions? So like the 4:30 mark is when I start looking on the halfway point is where I start looking through.
No.
If we have any questions,
from the podcast,
anybody have any questions with our live studio audience? You don't have to get up and speak.
patented means the data is real. Patented means that it came from the, pardon? It doesn't change the way any of us work. When you can patent a specific frequency sequence, it means that the data is bomb-proof, credible. And that's not like you did it in your high school lab. It was done at the Feinstein Institute. And yeah, that's a good point. But it also means that when you run concussion in Vegas on somebody, you have the confidence of knowing this is what it does. And it really does what we think it does. They only tested the 5 frequencies that are in the vagal tone protocol. Concussion in Vegas, I got no data on that, except that we know that concussion raises serotonin and Vegas raises heart rate variability. Pretty good, and reduces inflammation. So now we have data that says that. I love data. I love credibility.
I know there is such a fine line though between having data, needing data, using data for the confidence, right? That you feel this is safe and this is effective and this is what I'm going to do. And then just being like, I'm going to try this and I don't know if it's going to work, but it's safe and it can't hurt and it might help. And not having the data and just going where you're led.
Oh yeah.
With a hypothesis, right? Like we're not just throwing.
You create a model, and in every single 5-day class, around day 3, somebody will ask a question like, how would you do this, that, or the other thing? And I look at them and say, you understand it's not like we know what we're doing. I created a model that seems reasonable, but we have no proof that on a cellular level, we actually are doing what we think that we're doing. We just don't have any proof. And I have to be okay with that because my job is to send this patient out feeling better, being healthier, being out of pain, having a life. What's next? That's how we roll. And to have data means it's not a placebo. Placebo's 30%. What are your numbers in nerve pain? I'd say 90+% is not excessive, not an unfounded claim. What are your numbers in terms of resolving or softening or reducing scar tissue? What are your numbers? Clinically, Kasha says 100%. I'd say, yeah, it's pretty close to that.
Like that part's easy, right?
Yeah, it's like scar tissue is easy.
Yeah.
Nerve pain's easy. Neck pain's complicated.
Yeah. Yeah.
Nerve pain that's caused by a disc. You have to heal the disc. Treating the nerve pain's easy. Fixing the disc is 6 weeks, sprained ankle in your low back. And that 6 weeks start from the next time you do something I told you not to do.
And so I'm just thinking, you were talking about how things are easy in success, right? And then you start fixing everything. And then you start getting picky.
Did you skip the part where you flat out fail, right?
No, I'm going to get there.
Okay, good. Just checking.
So when I have somebody who is challenging, right, and I can reverse nerve pain in 10 minutes and it lasts in the clinic and they leave and they come in at 6 out of 10 pain and they leave a 0.
Yay.
And they're right, but it comes back. So now I can say that's a good face because that's exactly it. So to me, we talk about, is it just a party trick? Yes. Yeah. I got somebody's shoulder to go from here to here. I was like, oh, you're amazing. You're like Jesus. Great. But tomorrow it's going to be exactly back to where we started. And I'm not okay with that. So that's where all the fun stuff that I get to do in the sports course, the patterning, the recruitment, the balance, proprioception, getting all the things at home that we can do to get these things to stick. And then you have the stable state that you have to know your limitations about.
Oh, and getting the muscles to fire all in the right pattern and then strengthening muscles that haven't communicated with your brain in 15 years.
I love that stuff.
Yeah.
Give me that stuff all day long. People that were in my class, like that's what we got to geek out with all afternoon is, and also I want to just say too, saying the right verbiage, like your glutes are not weak. They're inhibited. They're offline. There's a very different phrase to say you're weak, that's weak versus it's just not online right now, but we can get it there.
It's just inhibited. And it's inhibited because that is scarred to that on the other side. So we're going to get rid of the scarring. Wait, I have a hamstring tear. Why are you working on my groin?
This is where biomechanics comes in.
Yeah.
You can do your little explanation. But like the closing of the case, so we're talking about like the statistics between nerve pain and scar tissue. That's just easy until it's not, and then you can't figure it out, or until it comes back. So like we are all mortals here. You may not be, but the rest of us have.
Kevin says I'm not allowed to die, but that's not going to happen. Don't tell him.
But the failures teach us, right? We learn from them. And you always say there's nothing that we have done that you have not already failed at. And we learn, I think, more from the failures than we do from the success stories, right? So that's the encouraging part about what we do is here's the recipe and try it, but here are all the other options that it could be and try that. And then tell me.
Yeah.
So that I can
exactly.
do it too when I get stuck.
The other places where you can expect failures are surgeries that shouldn't have been done in the first place.
Yeah.
Surgeries that were done by the wrong guy at the wrong time of the day. Surgeries, did I mention surgeries that shouldn't have been done in the first place?
Yeah.
And then surgeries where the surgical technique simply doesn't make any sense to anybody that knows anything about neurology. Tarlov cysts. Patient had to charter a jet to fly from New York to Portland.
Let's back up one. We all might know in this room what Tarlov cysts are, but for the lay people listening.
So her Tarlov cysts were in her sacrum. She had them at all 4 nerve roots that leave the sacrum. And the dura extends out on the nerve root. There's the dura, the pia, the arachnoid. And she's over here, Joe. The dura, the pia, and the arachnoid. And there comes a point when there's scarring at the nerve root. And the arachnoid doesn't absorb the spinal fluid because it can't. It's scarred down. Now, in our world, if you can catch a Tarlov cyst, theoretically, what we would do would be to take the scarring out of the arachnoid, right? Because we could do that. Scarring out of the dura, scarring out of the pia, just, and then hope for the best. I don't know if it would work. It's the surgical repair twice now. This lady flew from New York in a private jet because she could only lay on her stomach.
Wow.
Got to Portland. I saw her on Monday. Whoa. She wasn't kidding. She can't lay on her back. She can't sit. She can only lay prone. So there's no pressure on her sacrum or this Tarlov cyst. Because the surgical technique involved taking off the roof of the sacrum. If you're going to throw up, do it that way. Taking off the roof of the sacrum and then wrapping the Tarlov cyst, compressing it around the nerve. He got rid of the fluid. So he's happy. He forgot that many models of nerve pain simply involve compressing the nerve. So he got rid of the fluid, so he felt good about it. And it was wire. So I treated her day one for nerve pain. Couldn't get it done. From the sacrum to the end of the nerve root, down under her crotch. Couldn't get it done. Day two, couldn't get it done. Day three, sent her home. So that's probably the most traumatic failure I've had because there's nothing that can be done. There's no way to undo what he did. Abdominal surgeries for aggressive abdominal surgeries for endometriosis. When they are so busy taking out the endometriosis, they forget that the pain nerve in the abdomen is the vagus. And they cut sequence. Sorry, guys. Anyway, so those failures aren't your fault.
Right.
It's not a good idea. You have to be very diplomatic when you tell the patient that the surgeon screwed up for various reasons. But I can't fix what was done is a reasonable thing to say. And you're going to run into it at some point.
Right.
You okay?
Yeah, it's
Gross. Yeah.
yeah, I'm getting when you do such a great job of visualizing and taking us, at least I just go right into the sacrum.
Yeah.
And that had to have been,
That was tough.
yeah.
This is why we do not keep adult beverages in the clinic.
For your sake or for theirs.
For mine.
Okay, so that was a big failure, but is that even a failure though? That is just, I think, knowing like limitations.
Can't put tissue back that's not there.
We do in the sports school.
Shit.
Just kidding.
Well, partial thickness tears, yes.
Yeah, and we can floof atrophy and,
Oh.
but
Neuropathic atrophy is like easy. Hello.
duh, just saying. But you're right, like we're not growing back completely degenerative cartilage, or we have
Right.
to know what our limitations
Although
are.
David Murphy.
I know he did it, I know,
one.
so that was the whole
It's-
thing too.
And
so
I
we-
don't understand how, so we're just gonna, maybe Diana Cross can explain that next time.
Maybe.
Okay. Where were you going before I drove the train and just, Brought
No,
us
but I
back.
think it's good for everybody. Like I said, we learn from our failures. So I think it's helpful for us to also learn like your failures, because you are the gold standard to which everybody aspires to be.
don't
So
tense up.
it is true. Let's just say that. So when you're saying, oh, it's just not that hard, and you're just like, it's really hard. What is she talking about? It is so hard. And I'm so bad because I can't do it. Like this is, I don't just speak for myself. I'm speaking for at least this room and at least the people that are listening.
All I can say is, if you do anything 200,000 times and you're not good at it, you should get another job. So it's mostly just mileage.
For sure. Yes.
Yeah.
Okay, so we talked about that. So is there another sticky situation that you found yourself in? Or what is another pathology that when you see is coming in, you're like, oh no, or here we go, or
It's like they got on a bus,
yeah.
strokes.
Oh,
Yeah, those are,
right.
and had a stroke that involved cranial nerves
Okay.
that I didn't have frequencies for, because at some point, George had frequencies for 10 different parts of the mitochondria. And all I said was, how will you know if they work?
Right.
Inner membrane, outer membrane, this membrane, that membrane,
Wow.
this, that, and the other thing. And it's, okay, I'll put the mitochondria as a whole on the list, but how will you know if it, apparently that annoyed him, because he stopped giving me the frequencies he was developing for other things like cranial nerves.
Right.
So this lady had a cavernous hemangioma. She had a stroke. The cavernous hemangioma was on the anterior side of her cerebellum, and it bled into the space between the cerebellum, the medulla, the pons, and basically trashed every cranial nerve between cranial nerve 11 and 3.
Got it.
She recovered from that stroke in 6 months. Very bright, PhD, I think. And then a neurosurgeon said that cavernous hemangioma is still there, waiting to break again. So we should do surgery on that. That's
just
good.
prophylactically, just
Yeah, just in case. So it doesn't bleed and get worse. She never recovered. After 2.5 years, she still had deficits in every cranial nerve from 11 to 3. And I had to text while she's in the room. I'm texting JJ, Ben, and Dave. Does anybody have the list of cranial nerves from George?
Oh,
And
someone
JJ did. He sent them to me. And then I found out, so her whole face, when somebody has a stroke, like a sensorimotor cortex stroke, the muscles are spastic, right? They're denervated. So they're not getting motor input. There were 4 or 5 frequencies for the facial nerve that run the muscles in the face. And her masseters were spastic, her pterygoids were spastic, her temporal. Every muscle innervated by the facial nerve was spastic. And we got all of them soft, except, this little dent here. Hers was really dented. There's actually a muscle in that little hole. I couldn't get that one back. So the good news was I could treat the facial nerve. That frequency was correct. She sees double and the surgeon wants to go in and shorten the eyeball muscles so that she won't see double. And let's see if we can fix the nerve that works the eyeball muscles, but I can't do that today. But I'll put it on a custom care and you can try it. And so that was one. And then the accessory nerve, and yeah.
How many other secret George frequencies are there?
And they all have a little eye next to them.
Yeah.
Because George douses for frequencies with little stick plates. Some people muscle test. And that's where we got the insulin resistance protocol. But George douses for him, and he does it off, if he doesn't have a patient that has a problem with that nerve, he'll do it off of Wikipedia. And there's no reason to expect that frequency is correct.
Right.
Just because it's George doesn't mean that the frequency is correct. So the Dura was a George frequency.
Wow.
That one we have proof.
Wow, that one is
The
like,
Pons,
yeah,
we have proof for that one.
Yeah.
So then the little eye comes off and it goes on the standard list. But
wow, the Dura is like one of the slam dunk gold standard frequencies.
wait till you see Eduardo's.
I can
I know.
imagine, I can
The
imagine.
symposium's like my total favorite.
Do we have a question? Oh, are we?
Oh,
gonna-
the cranial nerve frequencies, they're in the buddy for people that have taken the advanced and symposium. JJ put him there. And if he hasn't, I'll tell him it's okay, as long as he keeps the little eye next to him. Yeah, because one or two of them are AB pairs. What am I supposed to do with that? What
Hmm.
pathology in that nerve? Yeah. So I don't know. It's not my fault.
It's just, it's so interesting. I'm just thinking about the Dura, like that is wild. But that's a
Dura.
George frequency.
Yep. Dura, P, and the arachnoid weren't on the original list, and they all work.
The Dura works. But
25 years ago.
you know what I like about you is that you're a skeptic.
Oh, yeah.
The two greatest things that I've been a skeptic about I'm the two greatest champions, and that's rock tape and FSM. I didn't understand how tape on muscle could do anything. That's just dumb, but it works. And I talk about the story all the time that I was just like, what is that person doing with that little machine? Please. And look at me now.
Yeah.
But I think a healthy dose, going back to practitioners, I think a healthy dose of skepticism is actually good. You should challenge your thought and you should challenge things. I think if we were just blindly believing we were fixing people, we would just hook people up in rooms and leave. But we're testing and we're palpating and we're checking range of motion and we're checking strength and we're seeing gains. Like this is the clinical data to show that it's working.
And if I was the only one that was doing it, I wouldn't have to be so skeptical. We now have 7,000 practitioners in 23 countries.
Amazing.
So I, by God, better know what the heck I'm doing, right? So before I teach something and before I turn these frequencies loose on practitioners who trust me and who want to be able to help their patients, number one, you have to know that the frequency is correct. You have to know what to do with it, how to think about it, what not to do with it, right? And how to put it together with what you already know, how to look up the pathology. It's like my phone is hardly ever on airplane mode because I'm looking like, what causes a syrinx? I don't know. I have to look it up.
Yeah.
Because if you're going to treat it, you have to know what causes it. And then, so at some point, there's going to be how to treat a syrinx and why, once we figure out how to standardize it. But yeah, I got to be a skeptic, not for my sake, but for yours.
For everybody's. And like I said, I think a healthy dose is good. And I'm always like,
Prove me wrong.
I'm like, oh,
I like that.
okay, let's prove me wrong. There's a certain point where you want to be positive, like I said, and whatever, but being that skeptic helps us troubleshoot, right? So when it does fail, what's my backup? I guess that's how I think about things. If this doesn't work, what am I going to do? And what else could it be? And what else could it be caused by? And if it's not that tissue, what's around there?
Which is why the supine shoulder practicum now has a slide on the teres minor.
Yeah, as it should.
Yeah, because there's no way to fix a shoulder as long as the teres minor is like this. You has to be able to
Pec
do that.
minor, I mean,
Sorry.
I knew what you
minor.
meant. Yes,
Pec minor. You know
Yeah.
what I meant.
I do, because it attaches onto the core cord. So I think I actually called it on day 2 of the sports course, the little jerk, because it's a little jerk. The pec minor is not going to cause
So-
a shoulder problem, but it's going to hold a shoulder problem.
And it's a
jerk.
well-intentioned troublemaker.
I don't think it's well-intentioned at all. I think it's got Napoleon complex, to
No,
be
it
honest.
wants to protect the shoulder.
But
Don't
it's
move.
It's
That's dangerous.
Napoleon.
Why is it dangerous? Because there's adhesions between the brachial nerve, artery, tendon, vein
Yeah.
that run under it.
Yeah.
Yeah, like that. poor thing.
Well, it's
until-
told, it's safe to let go.
Yeah, and then by then, it's got little tendon tears that make it go tight.
Mhm.
And it still has adhesions between the nerve, artery, and vein that run under it. Poor thing. Tries so hard.
It does. So again, maybe you're right. Maybe it is well-intentioned. I just see it as little Napoleon that's just
Okay.
trying to tell everybody else what to do.
Could go either way.
Depending on how you're looking at things. We have a question or a comment. Yes.
Most of the ports that are put in for people who are being treated.
No.
are on the right side at the pit,
Nice.
right there.
Ports. So the comment was
Oh
most
my
of the ports
God.
for people are on the right side.
And then they take the port out
Yeah.
after they run chemo through the
Even
port.
after 8 to 10 months, sometimes a year or two.
Wow.
Wow.
So after that,
So have you ever had cancer chemotherapy or a port now becomes
Part of
one of
the
our
questions.
history questions? Or why on earth does your pec minor feel like that?
My alarm just
It's
went off.
not.
It is,
Okay,
it is 5 o'clock.
thank you.
Normally it's 4 o'clock, but thank you everybody for coming. Thank you everybody for listening. We are embarking on an amazing few days of knowledge and learning and collaboration and lunchtime chat.
excited.
I know, it's like the night before Christmas, right?
Thursday night, there's
Reception.
buffet dinner for faculty, instructors, certified students. Yeah, I'll do it. And then Saturday, the Ruth Johnston Award is a big deal this year because there's, number one, because almost half the people taking the course are taking it live stream. So we didn't use all our food and beverage money. So I moved the Ruth Johnston Award from lunch to a dinner banquet. So if you had plans on Saturday night for dinner, move them to Sunday or figure on starting them at 8:30. And we have 2 Ruth Johnston Award recipients.
Wow.
It's
That's a big
special.
deal. That's a very
Yeah.
special one.
And this year we are giving the LEAP Award.
Nice.
Yeah. Ha, I have secrets.
like a pro.
Huh?
The leap.
Leap.
Leap. A
It's
leap
like
frog,
frog.
Yeah.
It's for someone who takes a leap that involve, did you ever watch Indiana Jones
It's the best
and The Last
analogy.
Crusade, right? Where he's on that cliff and he can't see the bridge out in front of him until he takes a step. And in order to take that step, what did he need? Courage, determination, faith, commitment, all that. That's the LEAP Award. And it's only been given once before. I didn't give you the LEAP, did I? I did. So twice before. Jody Adams, Kim, and
To be announced.
to be announced. Yeah.
Very exciting.
Are we done already?
We're done.
We're done.
We're done. Thank you, everybody. We'll
Thank
see you
you,
all.
guys.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.